Catheter valve replacement now ready for all patients, for all comers. I didn't know that word, but I like that. So Professor Blankenberg, he's a big fish. He comes from the University of Hamburg. He's a board member of the German Society for Cardiology and a chairman of committee. He's a member of various international bodies, such as Functional Genomics Steering Committee of the American Heart Association. He's board member of the Morgan study, the lipid study, the Gutenberg health study, the Dedicate study. So, I mean, there's no better person to talk about this topic, and I'm happy and let you start now.
Thank you very much for this very kind introduction, and thank you for being invited here. It's always a pleasure to be in Berlin and to participate in this fantastic meetings. And Dr. Klein gave an excellent and very precise talk and set an excellent stage, so I was impressed about the level of consideration you did here. And just to take a talk that I have nothing to disclose except, going back. So it should be a joke, but apparently this picture is missing. I have to disclose I have a conflict of interest because I love cardiology and interventional cardiology, but it should not preclude that I don't love surgery, in particular with these highly innovative medical products. But anyhow, TAVI for all, I think we need to carefully consider what we are doing and where we are currently staying. I like to give 2 slides of background of Leonardo da Vinci, who did excellent work, and I loved this talk by Professor Sievers, who did excellent drawings, work, consideration, and it came to my mind that this was really a precursor of TAVI implantation. But coming now to the key questions. When do we favor SAVI? When do we favor catheter-based approaches? Stefan Wingendecker and Volkmar Falk just recently provided a very nice work in the European Heart Journal and took some considerations in this regard. SAVI and TAVI, both are excellent procedures for the right patient. And if we try to understand what we should consider for a perfect selection, we come to the conclusion that we certainly have to consider the different aspects, but also, and this is so important, anatomic considerations, valve morphology, the access. Do we have femoral access without complications, or is it impossible? Do we need to go through other access sites? What is with the concomitant diseases? What is with concomitant coronary heart disease? And there are many other factors. So it is a truly personalized decision. And the question TAVI for all comers is actually a question which is wrong, because it is TAVI for the best person and for the patient who benefit best from it. And this is a multi-coursed decision. So we don't enter, and I can promise to you, and I can take your concerns, we will never enter in TAVI for all. I'm pretty sure. I'm a cardiologist, but I'm pretty sure. But we probably elude this therapy to many, many patients. Why? First of all, I'm interested to survive my hospital stay. This is a minimum. And here, all studies, from the very beginning of very high-risk individuals towards the recent studies with so-called lower or low-risk individuals, they favor more or less 30-day mortality for the interventional approach. But this is not surprising, and you know this. It's not surprising at all if you do an intervention or if you do a bigger surgery. Most likely you have a benefit of 30-day mortality. But this is the precursor. This is not where I'm really interested in. I'm really interested in, if 30 days mortality is somewhat equivalent, that we have to reach the best situation for the patient in 5 years or 10 years' time, because we compare against the perfect gold standards, which we know that it takes us surgery through 10, 15, sometimes even 20 years. So the bar is really high. And naturally, if we have an interventional procedure which just occurred 10 years ago or so and became routine a few years from now, or a few years ago, we don't have much data for long-term comparison. And so TAVI and NOTION here, this is, I would call it preliminary data, provide a non-pre-specified analysis of 5 years mortality rate, which apparently is quite equivalent. And here also for 3 to 5 years long-term follow-up, this is out of study follow-up, I have to admit, is also comparable for the intermediate risk patients which had been treated during the partner and CoreValve studies recently. And you see here the curves are quite equivalent. But what really concerns me, also as a cardiologist, if you look at the most recent long-term 60-month, 5 years follow-up of the Partner 2 trial. This is an Edwards valve. It's we have valve-specific trials, so this is a disadvantage. At the Edwards trial, comparing in intermediate-risk individuals, long-term follow-up, out of study observation. So this is so important. People always mix it up. It's not a pre-specified endpoint. It's an out of study observation with a lot of limitations. But, and this is discussed back and forth, you observe a crossing of the curve around 3 years. So you have this initial benefit of 30 days or a few months. This is a benefit which is highly consistent for many, many studies. And then you see here the crossing of the curves, and we don't know exactly how, if you reach this point here, the curves develop between surgery and TAVI. But this is probably due to many, many factors at the very beginning. Had there been advantage or disadvantage factors for selection of TAVI or surgery? And you have to understand that these trials, I'll come back to independent trial strategy later, these trials set a perfect stage for TAVI, because these are highly echo core lab based selected patients who are most amenable for TAVI. So it's a little bit like you play Bayern München against Hertha BSC Berlin, if I'm provocative, but it is nevertheless a truly, truly perfect comparison and study. I just want to create a little bit of understanding why potentially the decision is not finally made at the current stage. So these are some considerations for short-term, intermediate-term, and long-term comparison between both procedures. What are the hemodynamics? Very important. We need to understand the hemodynamics, and you are the best audience to understand hemodynamics, even better than adult cardiologists. The hemodynamics is important, and we have two particular aspects. First, we certainly improve the orifice, and we have an improved situation by decreasing the mean gradient, comparing TAVI against surgery, so it favors both TAVI. And two most important lessons you can learn out of this comparative slides. First, you have a slight difference in favor for TAVI for both phenotypes, and this difference holds true over 5 years. So it's not disappearing over the years. It holds, at least at the data which is available, and this is very limited, in particular for NOTION, but it holds true over 5 years. So this is an important aspect. But, and I don't want to make this long story very short, there's another hemodynamic which is even more important, and this is a paravalvular leakage, PVL. Here, the older and the newer valve generation comparison, what you can easily see, there is, and you introduced it with this curve, a modern generation valve therapy without any paravalvular leakage, and an older generation with, and you can see it, you can observe it here in echo and in fluorescein, you see definitely a significant PVL. So we need to do all efforts to omit this PVL, and we succeeded actually quite well, and you have seen it very impressively by Dr. Klein recently. So why do I postulate we need to take all efforts for that? Because you can see that, again, two aspects. If the patient leaves or is discharged with moderate, minimal, or significant PVL, with a leakage, it holds true again during many, many years, and it translates into a worse outcome. And this is my biggest concern as an interventional cardiologist, but the concern clearly decreased because we have much better techniques now to tackle this particular phenotype and this particular challenge. So, but you always should have in mind that this phenotype discriminates between success and a little bit less success, but I'm not quite sure. It is very clear if you contrast moderate and severe against none or trace, you have a very clear difference. If you contrast mild, trace, none, I'm not entirely sure at the current stage how it translates in, let's say, 5 to 10 years towards outcome. And once a patient is discharged with this condition, it is very difficult, even with valve-in-valve or with other procedure. We have a lot of potential possibilities, but it's very difficult to get this fixed 100%. Nearly impossible, so this is one of the most important aspects. Durability, there's always a concern about valve durability, structural valve deterioration, in particular for TAVI. I think this is not really understood right now. I definitely feel, but it's still a feeling, that there's comparison. It's comparatively good or worse or bad or whatever between both types of valves, but the answer is not fully possible at this stage. It tends, surprisingly, that TAVI has a little bit better condition than the surgical valves, but again, we compared against old surgical valves in some studies here, so it's a very difficult aspect. I cannot provide you a perfect response. So, what is a life cycle? How to decide how to do? So, first of all, even if we select for many reasons surgery up front, you can then add after 5 years or 10 years with TAVI procedures. You can select TAVI first, but you need always have to have in mind what happens in 5 years. Are we able, because coronary situations and so on, to do a redo of TAVI? So it's, we always have to consider the life cycle of aortic valve treatment, and not only in children, but even also in 70 or 80 years old patients, because our lifetime expectation for women is 86, 87, and for men is a little bit lower, so it's a long lifetime expectation. Bicuspid valve, I don't want to allude too much because this will be discussed later on, just one slide. We are already able to tackle bicuspid treatment, bicuspid situations as well, but this is just a flavor. It will be discussed later on much better. So I want to make the point. We need to consider a personalized decision. It's based on leaflet calcification, anatomic, CT-based, echo-based, imaging-based information. We need to consider the calcification of the LVOT. We need to consider the risk if I implant higher, lower valve selection of conductance disturbance, but I disagree with some surgical opinions that this is atrial fibrillation, rhythm disorder, or conductance disorder is really a big problem today. It significantly improved, and it is definitely equivalent to surgery at the current stage. So this is not, in my opinion, the main problem we face now. But again, we have many, many phenotypes to consider, so that we cannot say TAVI is better or worse compared to surgery. It's dependent on many, many phenotype and structural aspects. So it's a conclusion, but I have 2-3 minutes later on for a different topic. TAVI offers superior short-term and still is still uncertain long-term. I have to admit it is uncertain long-term. The hemodynamics, I would say, are a little bit in favor for TAVI, but in long-term it appears to be equivalent because we don't know how this tiny superiority of gradient and orifice translates into heart outcome. We will learn this by some trials now. The life cycle definitely includes both surgery and TAVI, and a personalized decision is absolutely mandatory. And I just want to highlight, yesterday or the day before, we finally closed the recruitment of the DZHK here in Berlin, Deutsches Zentrum für Herz-Kreislauf-Forschung, BMBF funded and DFG funded, Herzstiftung funded, and so on. Dedicated trial, including all comers as best as possible, amendable for both treatment strategies, surgery and intervention, aged something between 75 and 85 years of age, and both randomized, and we reached finally the goal here. You see also Berlin has been recruiting very, very well. So we reached the goal with 1,517 patients. It's the only industry-independent study so far in this direction. It is so important to gain industry-independent proof for our treatment strategies. So we had been in big discussions with GBR, with many political, with the payers and so on, because it's a need for independent industry-independent proof. And finally, we closed recruitment, and we will have the first short-term results in 1 year from now. So I'm very, very interested to see if such a big endeavor contrasts results to that what we see by industry-sponsored important trials. So at the very end, we will definitely reach the goal of a fantastic result, clinical result, by having two fantastic options available to reach the Champions League. And it is absolutely also important, not only asking cardiologists, so these are the Hamburg cardiologists, it is important to discuss on a personalized level each patient according to phenotype, according to personal situation, according to anatomics, and according to everything. Think intellectual. It's an intellectual process to select personalized surgery or interventional decision. And my last sentence is, it is not the medical, or it is not the duty of a cardiologist to fight for TAVI, and it's not the duty of a surgeon to fight for surgery. It's a duty of the medical leadership to create a surrounding that makes the medical decision, independent of any economic and other aspect, the medical decision a best decision for the patient. And this is cardiology and surgery independent. Thank you very much.
Thank you very much. Very nice concept. And are there any questions from the audience? Yes.
Yes, Mr. Great. I have a question. I think that you said there's a certain long-term result with TAVI. Okay, that's okay, but it cannot be because TAVI is a very short procedure. However, if the long-term result is uncertain, is it okay that so many TAVIs are done because we do not know what happens in 10 years? Isn't it more okay to make one study for 10 years and waiting what is the result? Otherwise, we could have done a lot of damage to patients because we don't know the long-term results.
It's a very important question. That's no question. So first of all, we have, and I highlighted this at the current stage, observational longer-term results towards 5 and now 7, 8 years. But you are fully right. We don't know, and this is what I highlighted, we don't know a pre-specified 10 years result right now. On the other hand, as you started surgery, your brilliant surgery, you didn't also know if this, what you are doing, holds true for 10 or 20 years. So this is also, I think we have to consider this as well. But I also admit that we now are able to compare with surgical results in which we know that they hold 10 to 20 years with a fantastic success. So having said that, we also need to balance out the implementation of a highly innovative procedure where we are, due to phenotypic and other aspects, quite sure that this will hold true, the success will hold true for a longer time period. But I'm fully with you, and I always criticize, but this is also political, these are political aspects as well, that in contrast to UK and to US and Canada and Australia and so on, we have a healthcare system which enables early treatment prior to scientific proof. And this needs to be changed. It's currently changed. It's a process, but we need to fight for that.
Any other question?
Any other questions? Yeah. Please keep it short.
Yes, I'm an old surgeon. I have again a question. And my question is, you said very correctly that it needs a lot of parameters, personalized medicine. And my question is, how is the value of the non-invasiveness if you tell a patient and say, okay, maybe you need no surgery, but maybe you have a 3% more risk of a pacemaker? How do you value this?
Yeah, it's a very important question, and honestly, I cannot give a 100% perfect response. You need, it's always a medical. It's not only TAR in medicine. It's not only TAR. Many cardiovascular therapy selection based on individualized and personalized discussions and decisions, and we need to take, this is the only thing I can say, we need to take all information into account, everything. And this is why the structure, the infrastructure between the different experts needs to be in place. And my duty is to enable this in Hamburg, to enable this political and strategic and medical structure in Hamburg. And this is what I can say. Each patient will be discussed in the team and then afterwards with the patient himself. And I always tell the patients that we should not only look on some short-term aspects, but you need to understand long-term results. And I also have to admit, we did the DEDICATE study, and I tried to persuade patients to participate, and 90% of the patients I tried to participate who wasn't sure between, many patients participated, finally decided after I informed them for surgery, unfortunately. Not unfortunately, but for surgery. And because and Hermann Reichsbrunner always sends me to the patients, he cannot persuade for surgery. And this is, we need to interact to each other and take long-term, short-term, personal situations. So this is personalized, individualized medicine.
Super. I think this is a perfect topic for tonight. Okay, so we got to move on, and I'm happy to introduce Dr. Kolaschke from